Borderline personality disorder. Dr. Matthew Sager, Psychiatric Medical Director, St. Mary's Hospital, Madison, Wisconsin. Borderline personality disorder, BPD. What is it? Perceptions and current diagnosis. History. Causes. Facts. Co-occurring diagnoses and differential treatment. Evaluating safety concerns/suicidality, BPD. Initial impression, stigma. Better descriptive terms. Emotional regulation disorder. Current diagnosis. CEM4 need to have 5 of 9 criteria. Pervasive. Unstable relationships. Splitting. Example. Impulsive behaviors. Mood swings. Intense anger. Feelings of emptiness. Fear of abandonment. Identity disturbance, poor sense of self. Suicidal behavior or self-injury. Transient paranoia/dissociative states. Diagnostic issues. Problems with CEM4. 5 of 9. There are 256 different variations. 4 of 9 no diagnosis, but would look very similar clinically. CEM-V. Revisions to look at dimensional aspects of personality. BPD on same axis as depression, anxiety. NN too complex for clinical practice yet. Diagnostic issues. Cont. Issues that affect making diagnosis. Transient states. Medical illnesses. Situational stress. Sex and cultural beliefs/biases. Clinician feelings. Anger, disappointment, frustration. Diagnostic issues. Cont. In the end, the diagnosis focuses on ways of thinking and feeling about oneself and others that ends up affecting a person's ability to function. BPD history. 1930s psychoanalysts, i.e. Sigmund Freud. Divided psychosis, delusions, hallucinations, from neurosis, anxiety/distress. The area between the borderline was the difference that explained why some patients did not act one way or the other. 1960s psychiatrist Otto Kernberg. Personality Organization to Syndrome to Disorder, BPD history. Cont. 1980s and 90s increased research. From analytical to medicalization. CEM3, 1980. CEM4, 1994. CEM-V, 2013. BPD causes. Genetics, environmental, social and cultural factors. Twin studies show strong inheritance. Environmental. Unstable family relationships. Social and cultural factors. 1900s less unstructured time with more work/survival instincts, i.e. eating disorders in different countries. BPD causes abnormal brain functioning. Amygdala, center of emotion. Prefrontal cortex, complex problem solving. BPD. Whatever the cause, data shows the impact of this illness. BPD facts. 2% of U.S. population have BPD. Equal to population of New York City. Twice that of bipolar disorder or schizophrenia. 10% of mental health outpatient clinics. 20% of inpatient psychiatric hospital units. BPD facts. 75 to 90% of those diagnosed are women. Do women seek treatment more than men? Men with similar symptoms may end up in jail or with another diagnosis. 10% complete suicide in their lifetime. Comorbidities are rampant. Mood disorders, depression, bipolar, anxiety disorders, PTSD, and substance abuse disorders. Probably burns out or dissipates over time. BPD facts. Face studies. People with BPD are inclined to see anger and neutral emotion faces. Word studies. People with BPD are inclined to attach a stronger reaction to neutral words. Comorbidities and differential diagnoses. Mood disorders, bipolar disorder 1 and 2, major depression, dysthymia. Anxiety disorders including PTSD. Eating disorders. Substance abuse disorders. Other personality disorders. comorbidities and differential. Lots of overlap with impulsive behaviors and mood instability. Different diagnoses from different providers. Explaining diagnosis, John Gunderson MD quote. As an example that focuses on jargon-free explanation that patients can understand. BPD treatment, BPD high utilization of healthcare dollar. ER visits, inpatient medical/psych care. Hallmark of good care, multiple modalities. Alliance building to foster improved mood, behavior, social functioning and relationships. Treatment goals, containment of any safety issues, structure. Provide support. Involve patient in decision making. Validation. Treatment levels. Hospital step down or up, partial hospital PHP or intensive outpatient program, IOP outpatient therapy plus med management, sociotherapies, group, family. Treatment levels. Focus on the least restrictive means of effective treatment. BPD treatment, hospital care. Often contraindicated and can worsen behavioral issues. Hospital provides external control which can become habit-forming and cause BPD patient to attempt to gain control in negative fashion. Should be used only for acute safety stabilization. BPD psychotherapy, mainstay of BPD treatment. Specific types may be more effective. BPD psychotherapy, DBT, dialectical behavioral therapy. Pioneered by Marsha Linehan PhD. Focuses on mindfulness, acceptance and awareness of situations and feelings. Decreases intensity of emotions. BPD psychotherapy, CBT cognitive behavioral therapy. Focus, changing thinking will change behavior. Skill building/practice. Relaxation. Exposure therapy. BPD psychotherapy. Schema therapy. Reframing ways people view themselves. BPD psychotherapy, group therapies, interpersonal, family, DBT. Others, problem-focused. BPD medications. Role of meds, manage symptoms, though benefit is often uncertain due to symptom chasing. Goal is to treat comorbidities. Avoid dependence, abuse, risk of overdose. Classes, antidepressants. Antipsychotics. Mood stabilizers. Anti-anxiety. Other meds, antabuse/naltrexone/methadone. BPD medications. Treat comorbidities. Treatment plans, contracts with patients, makes expectations explicit. From crisis intervention, when to call providers, when to go to hospital, to roles of those involved, i.e. family/friends. BPD safety issues, suicide and borderline personality. 10% completed lifetime. Safety plans, limited pill supply, family support, crisis contact. Highest risk are those with depression and alcohol/drug problems. BPD safety issues, feeling unsafe. Goal is for patient to recognize when they need more active help and trust they will get it. Typical crisis, express concern, allow patient to ventilate, avoid taking actions but let patient be explicit about situation. Follow up after crisis, BPD and suicidal acts, John Gunderson, MD. Suicidal acts are a dangerous distraction from the patient working on attaining a better life. Dr. Gunderson views suicidal statements/acts as affecting a patient's dependence on others and an effort to be cared for.